Okay, wonderful. So I titled this Recent Advances in the Evaluation and Management of COVID-19. And so let's go ahead and get started. Let's first talk about the pathophysiology and the epidemiology very quickly. This is a screenshot very shortly here. This was just taken tonight of the Johns Hopkins count dashboard showing that worldwide we are over 10 million officially in terms of infected, and globally well over 500,000 deaths. And you can see that map is very lit up. I remember 6 months ago seeing this as little tiny dots in China, and so we have definitely reached pandemic phase. In terms of where we are in the United States, we certainly had flattened the curve a number of months ago, but as you can see here, as we look at the rolling 7-day average, the daily new cases, at least in the United States, is picking up. I took the liberty of also looking at daily new cases here in India, and we can see that they have also taken off as well and reaching about 20,000 new cases every single day. If we look at the course of the disease, this came out very early on, published in The Lancet, about the clinical features of patients infected with the 2019 novel coronavirus. And what we found was a number of different phases. Phase 1 was this phase before someone becomes infected, and this is the phase where social distancing, physical distancing is very important in terms of preventing infection. But once the patient is infected, there's about a 5-day period of no symptoms. This is the incubation period. And then phase 2 takes us up until about the admission to the hospital. That's where the patient develops shortness of breath, usually from hypoxemia, from lung pathology. The third phase is after admission, where rapidly after about a day or two, we have worsening shortness of breath going into ARDS, that is acute respiratory distress syndrome, and then perhaps even intensive care unit and ventilation. So you can see here the terms of how long each of these phases last. When we look at the course of the disease in a little different way, we see there's a population of people, given country. There's an infection that occurs here in phase 1. And then in phase 2, again, what we see here is about 80% or probably even more than that, because there's, as we're finding out, more asymptomatic carriers, but 80% or more have very small symptoms. About 20% or less go on to need hospitalization, intensive care services, or be on the ventilator. And that's phase 3. And we have focused, at least in the United States and around the world, I can imagine is the same, on focusing on trying to treat people in phase 3 of this disease. We have many more people in phase 2 and even more people in phase 1. And what we focused on is phase 3. This is at the end portion of the disease, at the end portion of when patients need medical attention. And we've coming up with medications that we can use to try to turn around a ship that has already sailed for quite a few miles by the time they end up at the hospital. And then finally, death in hopefully the minority of cases. But the thing I want you to focus on here is the 80%. It's the 80% that never end up going to the hospital. And the question is, well, why is that? And is there something we can do to reproduce the 80% in those 20%? Well, the answer to that question really lies in the cells of the immune system. It is the body's immune system that takes care of that. And we found out very early on that there may be something going on with how the coronavirus affects the immune system. There are 2 parts of your immune system. There is the innate immune system and the adaptive immune system. The innate immune system does not require formal knowledge of the antigen. It can go through and detect non-self from self. These are cells, for instance, like the monocytes and the natural killer cells.
Hello, Professor Roger.
Yes?
Yeah. Can you make your slides slideshow or a full screen mode? It's a little smaller actually.
Okay, let's see what I can do here.
Yeah.
How's that?
So, no, it looks the same. It's fine. Yeah.
Okay.
Thank
okay.
you.
So let's see if I can make it even bigger. There we go. So the monocytes and the natural killer cells are part of the innate immune system. They go around and they eat up foreign substances and then present it to the adaptive immune system. It's in the adaptive immune system where memory cells are made, where cytotoxic T cells are made. This is what we see in terms of memory cells. It seems as though, and we'll talk a little bit more about this, that coronavirus or COVID-19 is inhibiting the innate immune system. Now, generally speaking, young adults, children have very robust innate immune systems, but very poor adaptive immune systems. And the reason is clear. They haven't seen as many antigens as an adult has seen. In the adult, it's the flip. You see the adaptive immune system in adults being very robust, but their innate immune system as being weaker. And we believe this may be part of the reason why we see higher mortality as the age increases. So here was a article or a clip from an article from the Asian Pacific Journal of Allergy and Immunology that talked about these two parts of the immune system. And they say here that based on the accumulated data for previous coronavirus infection, it's the innate response that plays a crucial role in protective or destructive responses. They go on to say that active viral replication later results in hyperproduction type 1 interferon and influx of neutrophils and macrophages, which are the major sources of pro-inflammatory cytokines. With similar changes in total neutrophils and lymphocytes during COVID-19, SARS-CoV-2 probably induces a delayed type 1 interferon. Now, this is important because this might explain why it takes a week or so for these patients to have such damaging symptoms. They say here, in addition, no severe cases were reported in young children when innate immune response is highly effective. These facts strongly indicate that the innate immune response is a critical factor for disease outcome. Okay, so what else is involved? We found out very early on that oxidative stress is also very important in terms of COVID-19. Now, oxidative stress is caused from reactive oxygen species, which we'll talk about for those of you who remember your biochemistry. There's calcium dysregulation, myoapoptosis, mitochondrial alteration, abnormal muscle adaptation, impaired muscle regeneration. All of these things are associated with oxidative stress. And what we're going to see is that the patients that are the most at risk for ending up in the hospital with COVID-19 are patients with hypertension, renal disease, type 2 diabetes, elevated BMI. These are the very patients that have high levels of oxidative stress. When I was first starting out with patients 6 months ago, I was telling my lung patients that you're the ones that have to watch out, the patients with COPD, the patients with asthma. These were the ones that we thought were going to be the ones that were most impacted because we thought this virus was going to act like the influenza virus, taking out lung disease. That has not been the case. Patients with asthma and COPD have not noticed a disproportionate increase in hospitalizations. Rather, it's the ones that we didn't think were going to have a problem, those with hypertension, those with elevated BMIs, overweight, things of that nature. And this is where it boils down to is, as you may know, in the matrix of the mitochondria, we have sugars, fats, and proteins entering the citric acid cycle and NADH coming out in terms of reduced electrons. It's those reduced electrons going to the electron transport chain that allow it to come down that electron transport chain, pumping protons into the inner membrane space and allowing for the production of ATP. However, when this cycle gets overwhelmed by an excessive amount of carbohydrates, for instance, then you get this last electron acceptor, which is oxygen, which is supposed to be transferred into water by the exception of 4 electrons. When that doesn't occur, and when there's 1, 2, or 3 electrons that come on instead of 4, you form something called hydroxy radicals, hydrogen peroxide, or superoxide. And here's the problem with that, is this species known as superoxide is a very deadly molecule because when it accumulates, it can damage mitochondrial DNA. It causes reactive oxygen species. And so imagine we have a patient with hypertension, coronary disease, diabetes, where oxidative stress is already occurring in unmitigated amount. and the patient's scale is out of balance. Now put on top of that the whole idea here of oxidative stress from COVID-19. And how does that happen? Let me show you. ACE2 is the receptor for the COVID-19 SARS-CoV-2 virus. ACE2, however, is more than just a receptor on a cell. It is coated throughout the endothelium. It is coated throughout the lung tissue. It's also seen in other tissues of the body. It's more than just a receptor and a way for the virus to get into the cell. For you see, ACE2 is an enzyme, and that enzyme converts angiotensin 2 into angiotensin 1,7. And that angiotensin 1,7 is very important as well as angiotensin 2 because angiotensin 2 promotes superoxide and angiotensin 1,7 helps break down superoxide. And in addition to all of that, when COVID-19 attaches to the ACE2 enzyme, that ACE2 enzyme gets deactivated. You have a reduction in angiotensin 1,7, an elevation in angiotensin 2, and that causes a burst of superoxide to occur. Now, imagine in somebody who doesn't have a problem with oxidative stress, they're able to absorb this hit, and they're able to, with the systems in the body like catalase, glutathione peroxidase, as we'll talk about, and other systems, to take care of this oxidative stress. But in a patient who has excessive oxidative stress and is leaning on the edge of the cliff, this infection is enough to knock them over. And you can see that that oxidative stress is going to cause excessive inflammation, and that excessive inflammation will go on to cause thrombosis, as we'll show. In addition to this, COVID-19 and SARS-CoV-2 attracts PMNs, which are neutrophils, and these neutrophils also release superoxide as well. So you can see here is a perfect storm, if you will, of superoxide reactive oxygen species. Now, what we have to quell this or to get rid of this, as you can see here, we have oxygen and we add 4 electrons, we will eventually get to water over here on this side. If there's only addition of 1 electron, we get the very dangerous superoxide molecule. 2, we get hydrogen peroxide. 3, we get hydroxy radicals. All 3 of these mid-species here are dangerous to the body, and the body has a way of getting rid of it through its antioxidant system. As you can see here, catalase, which requires iron, will convert hydrogen peroxide into water and oxygen. Superoxide dismutase, which requires copper, zinc, and manganese, converts superoxide into hydrogen peroxide and oxygen. And then the very important glutathione peroxidase enzyme, which requires selenium, will convert hydrogen peroxide into water. And so these systems are there, but if they become overwhelmed in a highly oxidized system, which we see very commonly, this can cause a lot of problems. So let's talk a little bit about the pathophysiology about what we think is going on. So the hypothesis is that SARS-CoV-2 causes a reduction in ACE2, as we talked about, increasing the amount of angiotensin 2, reducing the amount of angiotensin 1,7, increasing the amount of superoxide. It's this increased superoxide that causes endothelial cell dysfunction. Now, these endothelial cells coat the entire vasculature of the human body. And so you can imagine there is a lot of endothelial cells. These endothelial cells are coating the collagen underneath and the von Willebrand's factors underneath. These procoagulant factors, once they become uncovered, promote thrombosis. And so it's very, very, very important that the endothelial cell remain intact and prevent those factors from causing thrombosis. But if there is too much oxidative stress, the endothelial cells will become inflamed, will start to be oxidized, and that will release prothrombotic factors, for instance, von Willebrand's factor. And this was just published 2 days ago in the Lancet Hematology that showed that this very hypothesis has been proven correct in that they noticed in patients with COVID-19 on the regular floor versus in the intensive care unit that there is an increase in von Willebrand factor, there is an increase in procoagulant thromboses that we see. And this was recently shown in a New England Journal of Medicine article about a month and a half ago, which compared autopsies in patients with COVID-19 to controls. And it showed that there was 9 times the amount of microthrombi in the patients with COVID-19. So in fact, here is the article, Pulmonary Vascular Endothelialitis, Thrombosis, and Angiogenesis in COVID-19. This was published in the New England Journal of Medicine. They say here that in patients who died from COVID-19 associated or influenza-associated respiratory failure, they see diffuse alveolar damage. But notice what they say here, that alveolar capillary microthrombi were 9 times as prevalent in patients with COVID-19 than in patients with influenza. So clearly, an attack on this thrombotic process is going to be key to quelling and reducing the morbidity and mortality of COVID-19. Here's a photomicrograph of a histological slide. You can see here very clearly the white area is where the alveoli and the air exchange is. And you can see that this is the infrastructure and superskeleton of the lung. And these are capillaries. And instead of being open and allowing red blood cells to pass, you can see here clearly that they are thrombosed. So no blood can travel through here. And if no blood can travel, oxygen exchange cannot occur. The patient becomes hypoxemic. And this is what the CT scan looks like. We see ground glass opacification. Even though the lungs themselves have beautiful compliance, even though the lungs can expand clearly, you have significant hypoxemia. And this is the reason why it would explain perfectly why we're seeing patients coming into the hospital able to talk on their cell phone, order their next meal in the hospital, yet be severely hypoxemic. So what is the management of this? So the only medications, at least in the United States, that have been FDA approved and have been shown using randomized controlled trials of any sort is one of them is remdesivir, of course. This is out of the ACT trial. Initially, they planned to enroll over 1,000 subjects, but they had a quick peek at the data to make sure that there wasn't an endpoint that was met, because it would be unethical to continue that study and give placebo out if there was an endpoint. Well, there was an endpoint that was met. It was a modest endpoint. It showed that there was an improvement in time to recovery, 11 versus 15 days. There was a mortality endpoint that was not met because it was just above statistical significance at just greater than 0.05. Not a game changer. Have to treat 28 patients to save 1 life, although 1 life is always valuable. We would love to have this number needed to treat number much less than that. One area where you cannot give remdesivir is in renal patients, GFRs less than 30. Out of the UK, the recovery trial showed that dexamethasone at 6 milligrams intravenously daily for 10 days was helpful. Actually, much better results here. Those that were just on oxygen, number needed to treat, again, 29, not a game changer. But on the ventilator, these are the severest patients, there was an improvement in mortality from 40.7 down to 29%. That's an absolute risk reduction of about 12 to 13 points, translating into a number needed to treat of 9. That is significant, especially considering since dexamethasone is pretty dirt cheap, as we would say in the United States, and therefore you could save literally 1 life with just a few dollars. What about antibiotics? Well, these patients rarely have superinfections. I would say about 10% or less. So if it fits, go ahead and start antibiotics, but there's no antibiotic that's going to cure COVID-19. You could consider getting a gram stain culture and sensitivity. I would use the guidelines. If this is a patient that has been in the hospital for more than 3 days, you might want to cover bacteria like Pseudomonas or MRSA, methicillin-resistant Staphylococcus aureus. What about NSAIDs and acetaminophen? Well, again, if we're trying to inhibit the body's response to the virus, that may give us untoward situations there. So we may not want to do that. I think blood clots are the central issue. The question is what do we do with it? We know that blood clots are the issue. We don't know how to deal with it. Some people are saying that if the D-dimer level is greater than 1 microgram per liter, that indicates an 18-fold increase in the odds of dying, and the patient should be not on just prophylactic doses of anticoagulation, but full doses of anticoagulation, such as a heparin drip or full dose enoxaparin or low molecular weight heparin. And these are coming out of journals like The Lancet. There's also some evidence that would seem to indicate that patients should be discharged from the hospital on full dose anticoagulation. We've all heard these very unsettling stories early coming out of China where patients would be recovering and be discharged from the hospital only to go home and be rushed back to the hospital a number of days later and die because they thought they were recovering, but in fact they didn't. This seems to fit with the idea that even though the lung problem may be done, the vasculitis issue is not done, and patients may be developing thrombosis, again, because of this oxidative stress that we're seeing. Convalescent plasma is the addition of plasma from patients that have recovered and presumably have antibodies against the virus, and infusing that as a passive immunity tool in patients that are battling the virus currently. We don't have any evidence that this works. It is currently available, at least here in the United States, only through a trial. And so you have to sign up to be a member in that trial to be able to give that. There's a number of trials that are ongoing, and we usually can get that through our local blood bank. I'm sure that there's other ways of getting that as well outside. Again, no randomized controlled trial data that I have seen, at least, on convalescent plasma. So let's go back to our graph here. Again, phase 1 is preventing infection. Phase 2 is taking these patients that have tested positive for COVID-19, okay? But yet they're not sick enough to be admitted to the hospital. Here, I believe, is a missed window of opportunity. The patient is positive. We know that they have the disease, yet they're not sick enough to be in the hospital. And there are potentially millions of these people. What can we do with these people to lessen their progression to phase 3? We know a lot of work is being done in phase 3. I fear not much work is being done in phase 2. So what are the things being looked at? I think vitamin D is really high up there on the list. Look, there's a lot of evidence that patients who do poorly have a lack of vitamin D, and those patients that do well have no deficiency in vitamin D. Is that a associative relationship or a causative relationship? I don't believe we know the answer to that yet, but vitamin D keeps coming up over and over and over again. We also see, for instance, people of dark skin moving to high latitudes. These are the very people that are highest risk for getting vitamin D deficiencies. We know that it takes more time in direct sunlight in dark skinned people to have enough vitamin D made. And so these are the people that are at risk when they move to high latitudes. These are the very, very people that we are seeing that are having a higher risk of mortality in COVID-19. There was a study that was recently done in England. So it's not a healthcare access issue like it is in the United States necessarily, because in England they have free access to anybody. Yet, despite that, we're still seeing disparaging mortality in people of dark skin versus light skin. We can look at the example in Finland. At the early aspect of this disease, the Finnish people had great mortality data compared to their Nordic partners like Sweden and Norway. And then it seemed as though it was getting into patients of African descent, and it spread very rapidly. And there was a problem there, especially in Helsinki in the early part of the outbreak. So the question is what would explain these sorts of things? Vitamin D is something that seems to be coming up over and over again. And so the question is what's the risk of putting people on vitamin D? It's a fat-soluble vitamin, again, but I've rarely seen somebody overdose from vitamin D. So I think there is an argument that's being made in that arena. What about vitamin C? Vitamin C is an antioxidant, and that would make sense based on what we've just talked about with the oxidative stress. But vitamin C has also been looked at Paul Marek's group out of Eastern Virginia Medical School in its possible role in sepsis, number one, and also in ARDS. These are things that are not foreign diagnoses in patients that are admitted with COVID-19. And so there may be an added benefit to high doses of vitamin C. And what the optimal dose is, we're not sure. Quercetin is a supplement that is seen in a lot of vegetables, like, for instance, onions, that has been looked at in Ebola. There's a study that is ongoing with a researcher from Canada and also from China that's looking at quercetin in COVID-19 in China. Why would we mention quercetin, though? Quercetin is something known as a zinc ionophore. What is a zinc ionophore? It's something that allows zinc to come into the cells. That is important because we have some good data that shows that high levels of intracellular zinc in vitro can inhibit coronavirus RNA-dependent RNA polymerase. This is the enzyme that reproduces itself in the cells. If you can shut down RNA-dependent RNA polymerase, you can essentially shut down viral replication in the host cells. So that's important again. And the next thing we have there listed is zinc. What about the BCG vaccine? Well, there is an associative benefit in countries that use the BCG vaccine, such as India, that have a tenfold less mortality than in countries that do not use the BCG vaccine. Notably, what are some countries that do not use the BCG vaccine? Italy, which we all know had a very bad run of coronavirus earlier this year, and of course the United States, which is having its time right now. So I think that more is looking into that. The theory is that the BCG vaccine, which is designed to boost the adaptive arm of the immune system, may have bleed over into the innate. And the WHO has looked at this and has found that even in populations where the BCG vaccine is given, not only do they see a reduction in tuberculosis-related diseases, but they also see a reduction in other diseases as well, like yellow fever, like Ebola, things of that nature. Other things that are being looked at is proning. So this is where we simply have the patient sleep on their belly, lie on their belly. I've been doing this personally. I take care of COVID patients personally. And this is what we've been doing. And I can tell you that the difference in oxygenation is astounding. I've had patients go from a PaO2 of 60 on 100% oxygen all the way up to 260 simply by turning on their belly. This is something obviously that we've been doing for many years in patients who are ventilated. It seems to have a benefit in those patients that are not ventilated. A vaccine, of course, is being looked at. There's many different types of vaccine, and each country is doing their own program. N-acetylcysteine is something I wanted to mention for two reasons. Number one, because N-acetylcysteine is a compound that can recharge glutathione peroxidase, which we talked about earlier as being one of the mechanisms that the body has of getting rid of oxidative stress. So N-acetylcysteine is good there. But there's another reason why we talk about N-acetylcysteine. You see, when the endothelial layers become oxidized and damaged, they will release von Willebrand's factor. Von Willebrand's factor is a monomer which polymerizes and then traps platelets, and this is what forms the clots. These clots, when they analyze them, are very platelet rich, and they have many von Willebrand's factors. So the way that von Willebrand's factors connect with each other is through something called a disulfide bond. And these SS bonds can be broken with thiol groups, SH bonds, if you will. Well, N-acetylcysteine is rich in these SH bonds, and so it's well known, actually, that intravenous infusion of N-acetylcysteine can act as a thrombolytic. And in fact, right now at the prestigious Sloan Kettering Institute in the United States, they're looking at a trial in COVID-19 where they're infusing intravenous N-acetylcysteine at 6 grams per day, continuous infusion, to see whether or not this improves the outcomes, because we believe that these microthrombi that we just showed you in the New England Journal of Medicine is key in the etiology of the hypoxia in these patients, and that's really what's killing them. Famotidine is, of course, a H2 blocker, and they are looking very similar to what we just heard about here in the last couple of talks about using computers to look at the structures of drugs to see how they might interact with the virus and prevent its binding. Well, famotidine is one of those drugs that came up in that analysis, and they are currently using famotidine in a trial, not at the typical dose that we would normally use, but at 9 times that typical dose to really overwhelm and see whether or not it prevents viral infection. Let's take a look about a couple of other things here real quickly. What about immunity enhancing intervention? So I want to talk to you real briefly about hydrothermal therapy. As we said, not much is being done to help patients who are diagnosed with COVID-19 before they get to the hospital. This takes me back to 1918. In the United States, during the 1918 pandemic, obviously this was before the discovery of penicillin. This was discovery before the FDA did not exist. There were not randomized controlled trials looking at drugs. And the hospital system in the United States was more of a patchwork. There was the military hospitals, as you may remember, in 1918, many of the troops were coming back from World War I and were bringing back the pandemic with them. And so a lot of them were treated in the Army hospitals. The Army hospitals were using the aspirin, which had just been discovered in 1899, they felt that the fever was what was causing a lot of the mortality. And so they felt if they could treat the fever, they could help the patient. So they were getting high doses of aspirin, trying to treat the fever, which we now know, of course, is the immune system's cry for help to try to fight the virus. There was about a 6% mortality in the Army hospitals. So that was not very good. There was a certain subsect, however, of hospitals on the East Coast predominantly called sanitariums. These sanitariums were run by the Adventist Church, and they had a strong belief in natural remedies. And so one of the things that they did, and this was not completely in a vacuum, it was just a few years later that an Austrian doctor by the name of Dr. Joreg was using malaria. So he was intentionally infecting his neurosyphilis patients with malaria because he found that the fever itself that was induced by the malaria was actually killing the spirochete, the neurosyphilis. And since they had the treatment for malaria, they would simply treat the patient's malaria after the neurosyphilis had been eliminated. And that year, in 1927, Dr. Joreg won the Nobel Prize in Medicine for his discovery. It was the very next year, in 1928, that we had the discovery of penicillin. And of course, the medical world has never been the same since. But if you look back at how we used to treat this, and if you look at these sanitariums on the eastern coast of the United States at that time, they used very similar heat therapy to heat the body up and then to cool the body down using something called hydrotherapy. They took patients outside into the sun to get sunlight, vitamin D. They were breathing fresh air. And so these types of techniques that were being used in these patients had an overall mortality during this epidemic of 1 to 2%, which was a fraction of the 6% that was being seen in the Army hospitals. And so that made me think of what is it that we could do now for these patients that are diagnosed but not yet sick enough to be in the hospital. And I think that another look needs to be done on hydrothermal therapy because I think, number one, this very well could be helpful. There's very good data that shows that hot and cold therapies can enhance the immune system. And it seems as though, as we talked about at the beginning, that this virus tends to reduce the innate immunity of the host. So that's number one. Number two, this is something that could be scaled up very, very rapidly. We don't need a factory. There's no there's no patent. There's no factory that needs to make the medications. All you need is hot and cold water, and you immediately have a treatment that you can export to any country of the world. Anyway, that's hydrothermal therapy. In terms of placental mesenchymal cells, they're looking at natural killer cells. One of the things that I would be remiss to mention if it wasn't is sleep. I'm a sleep physician, so sleep 7+ hours per night has been shown to dramatically reduce the amount of infections that patients can have. And then, of course, nutrition and oxidative stress. And our final slide here is about oxidative stress. So here we have the gentleman on the left. This is the type of gentleman that we see very commonly now in the intensive care unit, whereas the gentleman on the right, we're not seeing in the intensive care unit. And why is that? Because of oxidative stress, obesity, diabetes, cancer, cardiovascular disease. So how do you go from the right to the left? It is by a high carbohydrate, glucose, fructose diet. It is from a diet that is high in red meat. It is from a diet that is high in saturated fat. How do we go to the gentleman on the right? It is using whole grains, fiber, nuts, unsaturated fatty acids, fruits and vegetables, vitamin C and E, beta carotene, flavonoids, legumes, protein, starch, phytochemicals. These are the things that are going to put us in a better stance when the coronavirus comes around to our neighborhood. And with that, I will take any questions. I hope I did not go over time.